Hey guys, welcome back to my channel PhysioSaurus. In this today's video, I'm going to talk about the treatment of ankle injuries. Now, for those of you guys who haven't watched my previous video, please go and watch it because in the previous video I have talked about the ankle injury, and in the ankle injury I have discussed fracture, okay, fracture in detail, and sprain, which is your ligament injury. All right. So the thing is, about ankle sprain, I'll make another video and I'll discuss the PT management for the ankle sprain or the ankle ligament injury. But in this video that you are currently watching, in this video I have discussed about the treatment of ankle fracture. But you should watch the previous video first because both of these videos are interrelated. All right. Now let's talk about the treatment of ankle injury, especially ankle fracture. So the first thing is, what are the goals? So goal is, first one is anatomical positioning of the talus, which is very important. Second one is obtain a joint line which is parallel to the ground. And the third one is smooth articular surface. Now, if these goals are not achieved, post-traumatic osteoarthritis is seen. Now, let's talk about the treatment for stable injuries and unstable injuries because, of course, the treatment protocol differs in unstable versus stable injuries. All right. So, the first one is treatment for stable injury. In the treatment for stable injury, there is no reduction, there is no requirement of reduction. Second one is immobilization with only plaster splints till the swelling decreases, and then a below knee plaster cast is applied with foot in the neutral position. So this is the treatment for stable injuries. Now let's talk about the treatment for unstable injury. So for unstable injury, it requires a reduction and immobilization in the plaster cast. Now, here are some common unstable injuries. So the first one is fracture due to external rotation. Second one is fracture due to abduction force. And the third one is fracture due to adduction force. Now, I have already discussed which type of fracture occurs in due to external rotation forces, abduction forces, or adduction forces in the previous video. Okay, so I'm not going to discuss it in this video because this video is totally about the treatment part. So let's discuss it. The first one is fracture due to external rotation. Two types of management can be done. The first one is conservative method management, in which closed reduction is done, below knee plaster cast is applied, and after that, walking cast is applied after a period of 1 month. The second method is surgical method management, okay, where both malleoli are fixed back into the normal position. All right. So first, lateral malleolus is fixed with pin or screws, and then the medial malleolus is fixed with single screw, okay, single screw perpendicular to the joint line. So this is the surgical method management. All right. Now, a below knee splint is given in the initial stages and then later on a cast is applied. All right. Now, the second fracture is due to the abduction force, which is less common than fracture due to external rotation. Treatment is same. Abduction force is required to realign the bones. So there is during management period, an abduction force is required to realign the bone. And if this doesn't work, that means closed reduction doesn't work, okay, then open reduction is needed where both malleolus are fixed back into its place. All right. So this is the treatment part for the abduction forces, a fracture due to abduction forces. The third one is fracture due to adduction. Okay. So it is usually isolated injury. Okay. And small bone fragments can get struck in the fracture line, making closed reduction difficult. So closed reduction is very difficult due to where fracture occurs due to adduction forces. All right. So orif is needed, open reduction internal fixation is needed, where medial malleolus is treated first because it is more unstable. Okay. And I have already discussed, by the way, what is stable and what is unstable injury in my previous video. Okay. So please go and watch it, uh, where you will get knowledge about what is stable injury and what is unstable injury. Okay. I have actually say this one. This I have discussed in the previous video. So please go and watch that first video. Link will be given in the description box as well as comment section. All right. Okay. Now the next one is Medial malleolus is treated first because it is more unstable and it is fixed using two screws, one perpendicular to the tibia and another perpendicular to the fracture line, which you can see in this picture. One is perpendicular to the tibia, okay, and one which is perpendicular to the joint line. All right. Now, if the lateral malleolus or the lateral malleolus is present in the fibula, right? If the lateral malleolus is also fractured, then it is stabilized using plate and screws. So this is the management for fracture due to adduction force. Now the last one is fracture due to vertical compression. Okay, so fracture due to vertical compression can occur alone or with other forces. All right, and this kind of fracture can affect front or the anterior and back or the posterior edges of tibial plafond. In the previous video, I have discussed about the tibial plafond fracture, and in which I have discussed that it can only occur due to vertical compression and it is an unstable injury. Okay, and tibial plafond is the lowermost part of the tibia. So fracture due to vertical compression, it is again of following types. The first one is posterior marginal fracture. Okay, so if the fracture is not displaced, let's say that the fracture is not displaced, a below knee cast is enough. But if more than 25% of the joint surface is involved, surgery or orif with two screws is recommended in case of posterior marginal fracture. The second case is anterior marginal fracture, okay, anterior marginal fracture or tibial plafond injury. Now, in cases of anterior marginal fracture, it can involve either a crushed anterior lip of tibia or large bone fragment. All right. If crushed calcaneal traction is, if it is crushed, then calcaneal traction is used. Okay. So if the anterior margin of tibia or the anterior lip of the tibia is crushed, then a calcaneal traction is used, and if large fragment is present, okay, then surgery or orif is needed. So this is about the treatment or the surgical part of the ankle injury or ankle fracture. The next one is PT management. I've already discussed about the complications in the previous video. Okay, so the next one is PT management. See, there are certain goals. So for orthopedician, the goal is to restore the ankle motif back to its normal anatomy and to restore the position of talus underneath the tibial plafond. So this is the orthopedic goal. In rehabilitation, for rehab, the goal is to achieve full range of motion or a normal functional level is achieved. All right. Along with that, to regain the strength of plantar flexors, dorsiflexors, inverters, and everters. All right. Functional goal is to restore the normal gait so that the patient is able to walk normally. Now, here is the required time of healing. Okay. The required time of healing is 6 to 12 weeks, and required time of rehab is 12 to 24 weeks. All right. That may vary person to person, but this is the standard data. Now let's talk about the PT management for ankle injuries that is treated conservatively. Okay. So a cast is inspected for adequate padding, cracks, softening, breakage, etc. etc. Okay. So in the first week, MTP joint active exercises are performed by the patient. In the second week, isometric quads are also performed by the patient. And during 4 to 6 week, cast may be changed to patellar tendon bearing cast, okay, PTB cast. During the same time, isometric quadriceps and ankle plantar flexors and dorsiflexors strengthening exercises are also prescribed to the patient. Okay. After 6 to 8 weeks, cast is removed. Active assisted range of motion to knee, ankle, subtalar, and MTP joints are performed by the patient. Okay. Then isotonic and isokinetic exercises are suggested to ankle joint. And after 8 to 12 weeks, okay, after 8 to 12 weeks, self-assisted relaxed passive movement to ankle and foot is suggested. All right. Now there are some additional managements too. such as thermotherapy is given to reduce the ankle pain and edema. Calf muscle stretching exercises are advised. All right. Now, after 8 to 12 weeks, PRE, progressive resisted exercise to the ankle joint muscles, are suggested. Now, let's talk about weight bearing. Like when patient is suggested to bear weight on his or her ankle. Okay. So non-weight bearing with 2-point crutch is advised. All right. Patient climb the stair one step at a time with good leg first. Okay. अच्छा वाला पाँव आगे रखेगा, जो पाँव में इंजरी हुआ है वो पाँव बाद में. Okay. Now by the end of by 6 to 8 weeks, not by the end, but by 6 to 8 weeks, partial weight bearing may be allowed. Cane can also be allowed, and foot full weight bearing is gradually allowed by 8 weeks if callus is found in X-ray. All right. So this is about the PT management. Okay, for ankle injury, for ankle fracture that is treated conservatively. Now let's talk about the PT management for ankle injury that is treated surgically or ORIF. Okay. So for first week, rigidly fixed ankle fracture. Okay, in the first week, for rigidly fixed ankle fracture, active range of motion to knee, ankle, and MTP joints. Along with that, isometric quads and ankle exercises are performed. For second week, isotonic ankle exercises are performed. Along with that, PRE and passive exercise to ankle and subtalar joints are started by the end of 8 to 12 weeks. About weight bearing, so toe touch weight bearing for rigidly fixed fracture by the end of 1 week. By 4 to 6 weeks, partial weight bearing is done. By 8 weeks, progressive weight bearing is done. Okay, it is suggested. Okay, and then full weight bearing is allowed by the 12 weeks. So this is the general or the standard protocol for PT management for the ankle injury or fracture that is treated surgically. All right. However, these all of these things are given in the book, but in real life scenario, I'm not suggesting these to any kind of patient. In the real life scenario, please go and get yourself tested, get yourself assessed with a proper physiotherapist with a degree. All right. And you should do all the exercises as per prescribed by him or her. Okay. So this is not for clinician. Okay. This is just for the educational purpose. So thank you so much for watching this video. In the next video, I'll talk about something else.